what I want to focus in on now are the very particular issues that pertain to trying to look across cultures, either working within one culture with tools that were developed elsewhere or trying to make actual comparisons across cultures. And this raises a number of basic issues, philosophical issues that have methodological implications. One of the issues has to do with a fundamental stance about the nature of culture as constructing kind of cultural worlds, that we live within a cultural world, and some people would argue there are multiple cultural worlds. And if that's the case, if we take that term world, that metaphor world seriously, then maybe we actually have incommensurable systems, is to say we have ways of partitioning reality and experience that are fundamentally incompatible in some way, that maybe translation is impossible. And there is philosophical argument around this, and people who hold that position to some degree. I don't think anybody can hold it to any great degrees simply because the world itself contradicts it. The world itself is full of people who move from one culture to another, who stand between two cultures, and who eventually, although they might start off with a lot of difficulty, eventually are able to do a lot of communicating and a lot of sharing. However, it is true that even with that, even with people having a lot of intercultural exchange, people moving to a new place, people marrying somebody from somewhere radically different, that over time people still feel, even though they may feel lots of understanding, they may also feel degrees of estrangement and difference. So it does raise an interesting issue, if not about incommensurability, that is to say completely different measures, completely different dimensions and frameworks that cannot be put together, at least of persisting alterity, and even of persisting radical alterity in the sense of somebody expressing things that are really hard to understand. Sometimes that's more apparent than real. There's a very interesting story around this, just to give you an example of what I mean by this kind of radical alterity. Uni Weeken is a Norwegian anthropologist who did her early work in Egypt, and then at one point worked in Bali in Indonesia. And she was very interested by the portrait that had been painted of the Balinese by Margaret Mead and Gregory Bateson and many generations, Clifford Geertz and Hilda Geertz, many generations of anthropologists for whom Bali was a favorite place to study because of the richness of the culture and so on. But many people had portrayed the Balinese as very, very emotionally contained and smooth in a way, that people valued a kind of emotional smoothness and restraint. And some of the anthropology argued that this is not a question of people suppressing or hiding things. They are fundamentally different in their emotional experience. So she was a bit skeptical about this, but wanted to do some work around ethnography of health and illness, and she went to work there. And then early on, when she had hired someone to be her interpreter to work with her in the field, this young woman at one point, very early on in their work, said, Dr. Weeken, I need to go to Denpasar, to the capital, to deal with something. Could you lend me some money? So she lent her some money, and this young woman went off to the capital and was gone for a week or so, and Uni didn't know what was going on, and she came back, and when she asked her, why, what were you doing? She explained, well, my fiancé died. He was in a moped accident, motorbike accident, and he was killed. And this woman was smiling and mild. And Uni Weeken described, I heard her present this some years ago at a conference, she described this odd feeling, this weird feeling of how is this person reacting emotionally? This is very strange. So this is what I mean by this kind of radical alterity, this feeling like somebody's reactions are just hard to understand. They just don't make sense. In fact, so much so they may give you a kind of creepy feeling because you just cannot process how they're reacting. So that's the first pass, and that first reaction fit very well with the portrait that had already been painted of Balinese as maintaining this emotional equanimity even in the face of adversity and loss and so on, and this being had been portrayed as part of a kind of aestheticization of life, of maintaining the aesthetic harmony of the world as a kind of spiritual and social value, of maintaining a kind of socio-moral order. But over time, Uni Weeken observed other things going on. And she's wrote about this in some papers and in a very good book that I recommend to you called Managing Turbulent Hearts. And the title gives you a clue as to where this is going, because what she found later on was at some point that this young woman was off by herself looking very sad and off by herself crying and obviously going through a lot of emotional struggle. And so as she explored this more over time, what became clear was this appearance of equanimity, of mildness, of not being totally thrown off by the death of this young man. This is a woman in her 20s and a young man who died at that age. This appearance of everything being okay was not all that was going on, that there was inner struggle and suffering, but this was an achievement. This presenting of oneself in this smooth way was an achievement related to managing the difficult emotions, and the reason for that had to do with a set of cultural beliefs and social practices. And the beliefs included the idea that if you get very upset about this loss, you may get sick, because that kind of emotional turmoil will make you sick. Moreover, if you get very upset and express a lot of suffering, you'll make other people uncomfortable. And in fact, in terms of this woman's management of these feelings, other people around her were interacting with her in ways, joking with her, teasing her, saying things to encourage her to suppress and contain her feelings, not to express her grief in an overt, sad or tearful way. So there was a social process, and that reflects again the shared understanding that if you express your emotions in this negative emotions or painful emotions in this way, it will make other people sick as well. It will have a toxic effect for other people. And finally, there's a notion that if you express this emotional suffering, if it becomes something manifest and spreads, it will influence the person who died on their voyage and on their potential rebirth. So there was a lot at stake. And so the argument is, given so much at stake for your own health, for people near to you that you love, for the person you lost who you love, there's a lot of pressure on you to find a way to contain and manage this feeling. So this is an example where something that appears at first radically different ends up being different still, I think, because not every culture puts such demands on people in terms of how they manage it, although I would say every culture has prescriptions for how you should grieve and what's appropriate and when's enough and what's enough and what's too much and so on. But this particular pattern is distinctive for this cultural context. So the notion that we need to work with those differences and that our first experience of utter strangeness may really not be the whole story, that we can reach deeper levels of understanding, I think is mostly what people feel around the world. Nevertheless, I know people who've lived their whole life in another culture or much of their adult life who at a later phase in their life finally decide, no, I want to go back home. I want to go back to where I came from. And they feel like it's related to returning to the familiar, to the early, and so on. So there definitely has been a kind of stress and strain attached to, or that process of living elsewhere, or perhaps a new configuration of their identity that is returning to unfinished business or reclaiming things. It's hard to know which, but. So just to say then that I don't think that the argument about incommensurability, I'm mostly just using arguments now from everyday life experience, but I think there are other kinds of philosophical arguments that can be made, that the argument of incommensurability doesn't go very far. That is, we don't really live in separate worlds. We live in one world, but we live in separate communities with separate ways of life and so on. So given that we're in one world, there are points of contact and points of exchange and things that we have to agree on and work with. And of course, again, it's been a fact of human history that despite the emergence of separate cultures, there has been migration and movement across very disparate cultures. You think of the Silk Road going all the way from the Middle East through to China, and that having existed for a very long time, and there have been movement back and forth of all different cultures, so that you can find traces of the ancient Middle East in the Far East, kind of, and vice versa. Okay, I want to, having just made that brief set of remarks about incommensurability, I want to address two more basic philosophical issues around the category fallacy and the looping effect. And these are important ideas within cultural psychiatry. The category fallacy is a term introduced by Arthur Kleinman in a paper in 1977 called Depression, Somatization, and the New Cross-Cultural Psychology. And this is actually a quote from him, the lower part of the slide, where basically what he says is that if you take a category like depression, that has all these symptoms, and we say, this is what we mean by depression. You have these symptoms of feeling sad, and of not sleeping well, and not eating well, and losing weight, and losing interest in things, and so on. And you go and apply that category somewhere else. You may find people who fit that category, but that does not mean that that category of depression is the best way to describe what's going on in that other community. It doesn't even mean that that category is measuring exactly the same thing or capturing exactly the same thing in that other community. You don't know, in applying that category, whether the items mean the same thing for people. You don't know whether there are other ways of grouping things together, so people are being left out from that category who also are suffering, maybe in a similar way, or in some respects in similar ways, obviously not exactly the same symptoms, but other forms of similarity. And you don't know if your grouping is including people in that new context who would not have been included in the other context. So for example, you could think of depression another way. You could say, maybe depression is what happens with a certain predicament. Somebody has multiple terrible losses and feels like they don't want to go on. Let's just define depression that way. And now let's compare things and see what the symptoms are. Maybe you would find different things. Take a rudimentary example. Years ago, Frank Kortman described experiences using the self-reporting questionnaire, the SRQ, which is a symptom questionnaire developed by the WHO for some of the early cross-cultural studies. And he described what happened when you use this questionnaire in Ethiopia, in Addis Ababa. One of the questions, it's a very simple list of questions of distress, and one of them is, have you been crying a lot in the last week? And this is meant to be very concrete, very behavioral, very simple. Okay, crying. Crying must mean that you're sad, but we won't ask about sadness. That's a more difficult question. Let's just ask about crying. Well, it turned out that in that context in Ethiopia, when people went to funerals, they were expected to cry. Somebody else's funeral, whether or not you're closely related to the person, whatever, you're supposed to cry. And other times you're not supposed to cry. So this question that was supposed to be about an individual person's emotional state became a question about what events had happened in the community in the last 2 weeks. So you see the problem, even with the simplest kind of question of how the meaning could change. But the category fallacy is a broader question, a broader critique, if you will, around how our actual categories themselves may move or be transported across settings. And behind this is the notion, of course, that the meaning of a symptom, sign, or behavior depends on social or cultural context. That exactly something like crying doesn't mean exactly or always mean exactly the same thing in different contexts. So we need to know what that context is. And then our own tendency that once we have a category, all perception is through categories. We're always looking for a category. We're filling in a category. That's how we perceive things. So we're using those categories. And so the categories tend to be self-reproducing or self-vindicating. That's what we see. Yes, I see a bunch of depression. So it turns out, of course, that, as I mentioned, that if you do go around the world and you look for depression, you can find something that looks like depression pretty much everywhere. But whether that is the best description or the only description, or we don't know. So that's the category fallacy. So the question is, how do we avoid the category fallacy? Well, we have to take a step back and say, okay, I'm not going to assume automatically that the categories I have work exactly the same way, mean exactly the same thing in another setting. I'm going to make that an empirical question. I'm going to try to establish that. Moreover, I'm not going to assume that I have the best categories right away. Maybe there's some other categories, or maybe there's a modification of my category that would work. This is a reasonable question to ask, given that the categories we have come out of a relatively narrow segment of humanity. So the best way to begin would be to go and do qualitative research, ethnographic research, and simply say, how do people express suffering here? Or how do they express sadness? You can take our idea of depression and you can think of various items that are related to it. Sad mood, feelings of hopelessness, suicide, contexts where this occurs like loss, grieving, etc., etc. You can take all those and you can go and explore some of those and say what's going on here around this. If you do that, I mentioned last time, as Teresa Nell did in American Indian Reserve in the United States, you find that a lot of people are talking about loneliness. So you discover, okay, so loneliness is a concept. Let me start with loneliness at the center and see how loneliness ramifies. So you can explore loneliness. And then at a later point, you can start saying, okay, is loneliness the same thing as depression? Is it partially overlapping? Does it work better to explain long-term disability or healthcare utilization or giving up on life, or worse than depression? Or if I put the two together, can I get a better prediction of certain things? So there are a whole set of very practical questions you can ask, but you can only ask them, and you can study them quantitatively, but you can only do that first if you've put this other construct on the map. Maybe you decide, okay, loneliness is not a whole syndrome, it's just a symptom, but it's an important symptom. Maybe we can add it to our list of symptoms of depression and see how loneliness works as a symptom. Some years ago, Lloyd Rogler argued in the case of distress in looking at Puerto Rican immigrants in New York, that anger should be viewed as an important symptom, that it was not being included in the measures of anxiety and depression. And he found many people, their main way of expressing distress was anger. Anger at the system, anger at injustices in society. He said, why is that not being used as an index of other problems that people have, as a sensitive index of the fact that somebody's having a hard time? So that's an example where you'd say, okay, maybe it's not that we're going to end up with an anger disorder. Maybe it's not an anger disorder. Maybe this is just a socially acceptable way to, experience and express another facet. And we know, for example, in the case of depression across cultures, that irritability is an extremely common symptom. And in fact, more common than sadness in some contexts, in terms of what people were willing to express or experience. Okay. To decide whether a certain symptom or experience is pathological, as it were, raises a whole set of issues. Because, take the example of depression again, sadness, at the mild end of the spectrum of what we're calling depressed moods, sadness is a normal emotion. It's an appropriate emotion to have in cases of loss. There are probably reasons for that, but at the very least it's a reason, it serves an important function of communicating to other people that something matters to you and that that you need their care and their attention now because you've lost something that mattered to you. So whatever else it may do, it certainly serves that function. If somebody doesn't show sadness, it has a negative, in an appropriate context, it has a negative effect on their social relationship. So there's a social meaning to that. There may be other functions of sadness. But to decide when is sadness too intense and too much, that we want to say, okay, now this is a medical problem, it's a health problem, it's a psychological problem, you're not doing well, that is a social judgment to some degree. If somebody comes to us and says, I can't bear it anymore, the sadness is unbearable, we might want to negotiate with them and say, it's very normal for you to still feel sad. Somebody in my family who suffered a terrible loss and was saying, when am I going to feel better? And so you just want to say, well, give it time. It takes a long time, and you want to normalize it in that sense and have the person wait. But there might be somebody else who comes in 6 months later, or I've seen patients in the emergency room who tell me they're terribly upset over the loss of their mother, and it really is bothering them. And I say, well, when did that happen? They say, 5 years ago. You feel, there's something that's not working right. The person should be able to move on, even if they think sometimes about that and might get sad. The rest of their life, they might have moments where they think about their mother and they feel sad. Fair enough. But to 5 years later, not be functioning well because you're preoccupied with that, that sounds like a problem. So the idea of functioning and the idea of there being normal processes of recovery and restitution, and when that doesn't happen, we're dealing with a health problem, is what gets built into these diagnostic entities. So that's also the way to validate a new construct. If we say, okay, it's not, for these people here, it's not about sadness and depression, it's about loneliness or it's about anger, but we want to say, when is that pathological? Well, we're going to be calibrating it against exactly measures of disability and dysfunction. That it's okay to be angry too, except that if it's interfering with you going to work or taking care of your children or doing all these other things, that's a problem. It's a problem. It may be a problem for you, it may be a problem for people around you, but either way, it's going to be a problem and it needs attention. So that's actual work that can be done with these constructs. The value of that is not only then describing problems in a way that makes emic sense, that is, makes sense locally and is tied to the local frames. It is, in fact, enlarging our conceptual universe of what problems are and how the body reacts and how social worlds react, and that may lead to fresh thinking about the nature of the problem itself. If we want to come up with a more general abstract portrait of the problem, again, in the case of depression, cross-cultural work suggests that feelings of fatigue and energy depletion are very prominent symptoms. So maybe that should be central to our definition of depression. That would reflect that cross-cultural difference. Then we can, at the most direct methodological level of replicating the sort of cross-national epidemiology, we could then make up symptom measures or interviews that build in these specific symptoms. And we can go and study them. So this was done, I mentioned the other day, this was done in Puerto Rico with the Puerto Rican disaster study, where they built a module to look for ataques de nervios. So you could literally ask people for these symptoms, and you could diagnose it. You had, just like you could diagnose depression, you could diagnose ataques de nervios, and you could go and do this kind of epidemiology with hundreds or thousands of people. And then you can ask interesting questions about, is ataques de nervios really just always co-occurring with anxiety or dissociation or depression or something like that? Or is it separate? Or does it, how much does it overlap? Does it have a life of its own? If you have depression and ataques de nervios, does that change the course over time? Does that influence help seeking and so on? So you can do all these things. So generally, this is an argument for the value of doing that ethnography, bringing in new symptoms, new symptom clusters if they exist, if you've identified them, and then seeing how they function to predict things like disability, healthcare utilization, outcome, and so on. In the process, it doesn't mean that you throw away completely the existing categories. Notwithstanding the category fallacy, we're also taking part in a discussion and in a cross-cultural comparison. So we need these other categories, even if we're ultimately going to cast some doubt on their universality or even the way they're originally constructed, because we have to have a starting point and an anchor point to make comparisons. You can only change the initial measure by doing those comparisons and eventually saying, okay, we think we have a better measure now, and moreover, maybe that measure will work better even, we could run it back the other way, maybe that measure will work better in North America. Let's ask about anger and see whether it makes a difference now when we look at these symptoms. So behind this then is this idea that we're going to be challenging our existing categories of health and illness and not throwing them out completely, but expanding them. And that methodologically, it means that if we want to make that comparison, we have to keep some way of measuring that existing category, even if we're in doubt about it, because it lets us make the comparison and then put them head to head and say which one is a better predictor of a certain outcome we want. And I should say that this has not been done very much. I did show you, again, I think in a previous lecture, one such study that used, in Africa, that used a symptom pool that expanded the existing measure of depression to include things like heat or peppery feeling in the head and so on, and showed that some of these things were correlated, but actually concluded that none of these supplementary symptoms were stronger predictors of the depressive cluster. So it did not lead to destabilizing the depressive cluster. Actually, it gives a bit of evidence for the idea that that core depressive cluster actually works in Africa too. People express other symptoms, but the things that is most discriminating, that hang together in a particular core cluster that we could call major depression, looks pretty much the same in that context. Fair enough. That may turn out to be the case across the board. It's not been done in many other places. We have a little bit of that in Spanish-speaking countries. We have that in Africa. We have a little bit in South Asia. We don't have it in most parts of the world. And I would argue that it's work that's worth doing, even though some people have already said, well, we know depression is universal. We don't need to do any more work on it. If we find differences, so let's say we've agreed now we think we know what depression is, sort of, and now we're trying to study depression. And now we find a slide, like I think I'm going to show it to you again here, like I showed you the other day. Here's some differences from a cross-national comparative study using a structured interview on depression, and we find these enormous differences in the prevalence of depression. The question is, are these real differences? Right? If they are real differences, that's very interesting. First of all, it's interesting to each country to decide. I mean, it's a big difference if you have 3% of the population that have depression or 15% of the population that have depression. That's a big public health implications for that and so on in health services. It also could be a really interesting scientific clue that, okay, so what's going on? How come these people have 5 times the level of depression? What's going on? How would we know that that's a real difference or that that's just a methodological difference? How are we going to figure that out? Because there are a lot of possibilities. I mentioned before. It could, first of all, be that we're not looking at the same kinds of people, that in one setting, everybody with depression is being included in our sample, and in another setting, they're not being included. We could be asking the symptom the wrong kind of way. There's an earlier study where people looked at social anxiety in Japan, and they asked people the usual questions about social anxiety, and they found relatively low levels or moderate levels. Whereas we know from ethnographic work and from the history of Japanese psychiatry that social anxiety has been an important symptom, that people have paid a lot of attention to it. So something funny is going on. When you put in symptoms related to what I described the other day as taijin kyofusho, the offensive type of social phobia, in which you talk about, have you had feelings of being concerned that you were offending other people with your behavior, you find the level of social anxiety is much higher. So it could be that we're not including, even though the construct, the general construct is there, social anxiety, generally speaking, is there, we're not using the right symptoms. And that becomes a special problem with these interviews I mentioned the other day. The way a lot of these diagnostic interviews are structured, there are key questions, because they're long, because you don't want to ask everybody every single question. There are key questions that act as kind of filters or gatekeepers to decide, do you go into the rest of the questions. So for depression, let's say, there might be two key questions. Have you been feeling sad or depressed, or have you lost interest in your usual activities? So depressed mood and anhedonia, loss of pleasure in everyday activities, which is a core symptom of depression. If you have either one of those, you would be asked other questions about being suicidal, having sleep problems, lost appetite. But if you have neither of those, you've been asked no more questions. Now, it's possible, in fact, it can be shown, that there are people who have neither of those and who have all the other symptoms of depression. Now, whether that's just because they don't describe their depression that way or because they didn't understand the question or a lot of different cultural things, it points out the problem with putting a lot of weight on a few questions that may turn out to be not sensitive enough to what's going on. So this is another dilemma about how to ask about these things. And these are, in a way, means that there is a difference, but it's not the difference you thought was there. In other words, the actual level of distress people might be similar, but the shape of the distress is different. Third issue, the third issue I have here is really related to the first issue because it's an issue of mental health literacy. If you start asking people about being depressed and understanding their problem, you're also relying on people's own ability to describe themselves. And that depends on a healthcare system. And so, in fact, we think part of what's going on, part of why the rate in the Netherlands is so dramatically high is because it's a culture in which everybody knows about depression and psychology and whatever, and it's been quite normalized to talk about feeling depressed. So it just doesn't, it's prevalent in people's minds, and it does not have perhaps the same level of severity attached to it. So teasing apart all of these elements, and including these issues, the broader issue of the category fallacy and these differences in idioms, is a challenge. Underneath it all is if we can establish meaningful differences in a similar construct, then as I say, we have clues to potential social, biological, other kinds of differences between populations that could be important, not only in terms of health services, but in terms of understanding the basic causes of illness. So to do that, we have to have valid measures, and this gets us into a whole set of issues, of methodological issues around validity. And I'm going to say a few things about that. First of all, just to point out that there are many kinds of validity. I mean, the basic idea behind validity is the thing that we're looking at what we think it is? You know, I mean, very basically, we're trying to measure depression. Is depression what we say it is, and are we measuring it accurately? So there's a whole cluster of things around that. Diagnostic validity, I mean, we say, is this label really what we claim it is? Does it have the implications we claim it is? Nosological validity, we say it's depression, it's not something else. Is that a valid distinction to make in this population? Clinical validity, if we attach this label in a clinical context, is it actually useful? Does it make the right prediction in terms of outcome? Does it make the right prediction in terms of differential therapeutics? So these are all contexts in which we're using notions of validity. And the point to be made about this, I mean, we can amplify more and more kinds of validity, is that validity is embedded in a system of meaning and use. You know, we have a concept, we want to use it for something. We're claiming that it works that way. Does it in fact work that way? So you can get a hint already of how we're going to test validity. We have to show that it's working the way that we claim it might be working. how do we establish validity? We have issues of content validity. So we say, okay, what we mean by depression is a type of problem in which people feel very sad, lose interest in their everyday activities, are slowed down, etc., etc., etc. So we have a domain that we're describing of things that we think are related. We think they're related for psychobiological reasons. And we want to then say, is our measure of this in another setting working the same way? Does it have the same content in effect? Does it hang together in the same way? We have a set of issues around criterion validity, where we want to know, if you assign this label, does it predict things the way that we want? And then we have the broader issue of construct validity, which really speaks to the underlying issues, the underlying questions. As I mentioned at the beginning, most psychiatric diagnosis, and this is part of why we're so consumed with problems of validity in psychiatric research, most psychiatric diagnosis has no independent measure of what's going on. The only measures we have are the symptoms themselves. So we're in a kind of vicious circle conceptually, and so there's a lot of work to try to stabilize those patterns and show they really hang together internally and they correlate in the way that we want. If we get to the point someday where we say, well, when you have this cluster of symptoms, it turns out that this particular thing is happening in the brain, or it turns out that you can measure such and such an effect, then we might say, okay, we're going to redefine this thing based on that underlying mechanism now. And in fact, if we did know that and we went the other way, we might say, when you have this underlying mechanism, it turns out that there are a few other things that can happen too. We would have a whole way of reorganizing this thing. We're not there. But that would then give us a different kind of construct validity and a different way to test these things. At one point, I think I mentioned that at one point people were hoping that the dexamethasone suppression test would give us a biological marker of depression. About 20 years ago, so people were claiming that you could show this hyperactivity of the hypothalamic pituitary adrenal axis, and the way you test that is you give this external dose of a very potent steroid, and it would fail to suppress the person's own stress system because it was hyperactive. People thought, great, now we found a marker, and then it turned out it's a real phenomenon. It happens, but it's very nonspecific. There are lots of different conditions in which a person could have that non-suppression, and there are lots of people, maybe the majority of people with depression, who don't show that non-suppression. So it didn't work. And to this day, we have no measure. And one of the common fallacies that occurs in psychiatry is what Ray Prince called the therapeutic fallacy. That is, well, if it responds to antidepressants, it must be depression. So we have classes of medication that are given very specific names. So it sort of implies, antidepressants, that's what they do. They counteract depression. Antipsychotics, that's what they do. They counteract psychosis. Anti-anxiety medication. Well, first of all, those names are myths a little bit because the medications do many different things. Those are just how they've been marketed. Because they do many different things and because they affect many different systems, the fact that somebody is positively affected by them in one way or another doesn't tell us that much about what might be going on. Moreover, I mean, if you take an aspirin to stop a headache, it doesn't mean that what you were suffering from was aspirin deficiency before you took the aspirin, right? So there's several conceptual flaws with that way of validating things. So we still lack an underlying definition. I think I'll just, behind this idea of validity in medicine in general, that psychiatry is borrowing from medicine, is a kind of biological essentialism. I mean, the hope is, just as I've been talking now, depression will turn out to be really something in the brain with neurotransmitters. It's a very specific thing. It's problems of serotonergic transmission, and we can show that that's what it is, and therefore everything hangs together in a very particular way. So that's a different notion than the problems that we're dealing with might be an interwoven set of unrelated problems that begin to get tied together because of interactions and vicious circles and so on. That has a rather different epistemology. But because of this assumption of biological essentialism, the hope is that we're going to have these discrete categories and we can have diagnostic criteria. Underneath this is this notion that what we're searching for are what philosophers have called natural kinds. That is to say that nature divides into different kinds of categories on its own, right? If we look at the prototype of this is the periodic table of the elements, right? You have gold and you have silver and you have copper and you have helium and hydrogen. These are different kinds of objects in the world that most of us believe exist independently of human beings. Human beings found a way to describe this, more power to us, but we did not create these things. So they are natural kinds. And moreover, they have sharp divisions or distinctions. They all have intrinsic properties, essences. A small piece of gold is much like a bigger piece of gold, and it has very different characteristics than copper or helium or neon. And so that's the model of natural kinds. And the hope is, and the presumption of biological essentialism is, psychiatric disorders will turn out to be like this. They'll turn out to be natural kinds. Depression is depression is depression. Once we figure out exactly what it is, we'll know what it is wherever, and we're fine. Now, one problem with that is, to the extent that depression might be mediated by our own understandings of ourself, if those understandings change, the nature of depression changes. So this is what at one point the philosopher Ian Hacking called a humankind, a category that exists in the world because of how we interpret the world. A simple example of a humankind, let's say, is marriage. Right? I mean, that's a humanly constructed institution. We create marriage by saying, here's certain rules about how people will declare that they're formally bonded living together. You could argue that being attached to other people is a natural kind. That is to say, it comes out of our biology. But marriage is a very specific institution that differs in different societies, and who can, I mean, and witness the debate in our society and the transformation of our society that now allows gay marriage. So we've redefined marriage to include different kinds of bonding. So that is evidence of the fact that this is a humankind, this is a humanly constructed category. Interestingly, of course, the arguments, using that example for a moment, the moral arguments around this and the people who are upset about this and so on, often try to make a natural kind argument. They'll say, well, but you know, we know that that's not natural. And their appeal usually is not to nature, to human history, or to biology, but usually to the Bible or something like that, and saying that tells us that it's not natural or that it's wrong. But anyway, maybe I'm muddying the waters with this example. The point I want to make is that we have categories that are clearly in the domain of, this is the way we've agreed to divide things up, or we've created a new kind of institution, a new kind of activity. Money is another good example. And they would not exist if not for our beliefs and ideas and practices and agreements as to how we're going to do this. So that's a humankind. And the question is, what are psychiatric disorders? Are they natural kinds or human kinds? Or, as Ian Hacking suggested at one point, are they interactive kinds? They're mixed in a way. That is, they have some elements that are given to us and some that we're using to shape and reshape them, and that they're interacting with that. That's probably the most accurate picture, but it's a complex picture and a difficult picture to study. I'm going to come back to this idea because this is important, and this will be helpful for understanding the looping effect I'm going to talk about a little bit later. But I want to come back to focus a bit more on this issue of cultural validity, and to look at it from the flip side for a moment. How do we recognize that something is not culturally valid across cultures? How do we notice that? Because I think this is an equally important question if we want to say, well, how is it that we're going to become aware that there's a problem? Beyond me telling you I think there might be a problem, and maybe you, since you chose to take this course, you clearly think that culture is important, so we all share the same prejudices or assumptions, but you know, there are many people who don't. There are many people who are deeply skeptical that there's really any issue here at all, that believe that we already know the answers, or we can easily find them out in one place and transport them to another. It's not, human beings are not really that different, which is true to a degree. So how can we become aware of differences that make a difference? The question is, if you look around the world at people practicing in different settings, or when they get together in international conferences, do they in fact, mental health practitioners, psychiatrists, whoever, do they in fact use the same conceptual system, the same diagnostic system, or do they spontaneously say, it doesn't work, it doesn't fit, we use something different? Well, it's an interesting question. I mean, there is a Chinese diagnostic system that is a bit different. There are a few others. There are not many, but there have been a few national diagnostic systems that have been partly developed in reaction to the DSM that have some specific modifications in different language and so on. Mostly people use the same system, but many people within different systems will say it doesn't work very well. For that matter, there are many North American psychiatrists, many child psychiatrists especially, who will say they don't think the system works well at all. And there are many people that are don't fit and don't fit the diagnosis. In fact, it's a commonplace in training when we're trying to give people good cases that are purely this or that diagnosis, they're very hard to find. It's not how problems come. So there's already a little something funny going on there, and that's been swept under this sort of comorbidity rug where people say, well, these things co-occur and whatever, but it's very hard to find pure forms, and so that's an issue anyway. So the answer really is that there is some pushback or some evidence that things don't all work equally well, but partly because of the same processes that I argued underlie the category fallacy. If you give people a technology, they can certainly use it. And they can educate patients to use it, and they can insist on using it. And how well it fits or doesn't fit is an empirical question. And a clinician in their office providing services is not in a very good position to figure that out, right? Because if people were not happy with what they got, they don't come back. Or people who don't think they need what you have to offer, they don't come in the first place. So you have a relatively narrow window in terms of clinical. So clinicians are not necessarily the best people to ask this question to. It's really more of an epidemiological and public health and health services question, and that kind of research has been done to a limited extent. Some of it has been done. I don't want to paint a completely negative picture, completely skeptical picture of all this. I think there's lots that we know already and lots that's useful and so on, but I think the limits of it are not clear, and I think there's plenty of work to be done around that. There's one other part of this dynamic that I think is important and probably worth mentioning. It relates to the first lecture where we talked about the whole impact of colonialism in psychiatry. Because the fact is, if you go to an international meeting, I mentioned this also the other day when I said, there was a meeting of the World Psychiatric Association where the theme was one world, one language. Well, there is one language. The language is the language of international psychiatry and this vocabulary. There is a limited space within these meetings to talk about heterodox things, novel ideas being introduced from here or there. But the vast majority of the presentations are structured along the lines of existing diagnostic categories. So you put yourself in a very funny position if you say, well, I don't buy any of this, I don't want to talk about any of this. I have other things I want to talk about. You don't have a lot of people to talk to. You're kind of ruling yourself out to court. Moreover, I think until recently, many psychiatrists in different parts of the world have not felt free to raise these issues in a way. I think it's a dilemma, and I guess in alluding to the discussion on colonialism earlier, it's a dilemma of the kind of hierarchy built into the whole system, where if you are coming from an outlying region, a non-Western, non-Northern European, whatever kind of region of the world, and you have observations that don't fit, you're not in the strongest position in the world to sort of convince other people that you've now found something of crucial importance to how we think about psychiatry. And people don't, for the most part, do that. They're trained in a Western mode. They function in a Western mode. The reward system is in terms of your colleagues' attention and participating in these meetings and so on. I mean, if you want to be completely critical about it, the way that a person gets to go to the World Psychiatric Association meeting from a low-income country is by taking part in clinical trials funded by drug companies who then pay your way to go to the meeting. So it's only by having become a very intensive participant in a whole process of working with these categories to show that certain drugs will treat this category, et cetera, that you then experience this perk of getting to take part in a lovely meeting in a faraway place in a fancy hotel, et cetera, et cetera. So, and I don't, these are me and my colleagues and everything else. I don't want to sort of, make it too, be too critical about all this, but you can understand how it's not a system that's set up to create a lot of space for people to say, it looks very different where we are, we think we need to rethink this, we think some other work should be done, and so on. That does happen, but that's not where most of the energy and effort goes. Within the World Psychiatric Association, there is a section on transcultural psychiatry. It was founded by Henry Murphy from McGill and other people, and it goes on, and as I mentioned, the journal that we publish is now the official journal of that section. I would say it's one of the smaller sections of the World Psychiatric Association, and it's not, crunch, it's not one of the the hubs of activity or whatever at those meetings. There's much more investment in what is similar and what is translatable across different settings. I hope it's compelling, at least in the sense that these are questions worth looking at. I'd have to say, again, that I don't think that we have a huge amount of evidence that all these differences make a huge difference for everyday psychiatry, that research has not been done. And as I mentioned, the few times when people have done it very, very rigorously, they often have not found a huge effect. And I'm quite comfortable with that. I'm not saying it has to turn out one way or the other. I'm just saying it has to be done. It's not fair, and it's potentially very foolish not to do it. Having said that, are there other ways in which I think culture makes a huge difference, fundamental difference, and those also need to be documented, and some of those need to be documented purely on qualitative basis. In other words, there are times when people are trying to offer a treatment to somebody that is totally beside the point in terms of what that person wants and needs. You don't need a big quantitative study to do that. You need a good experience near listening to the person, documenting this is what they said, this is what they wanted, this is what happened when you did this thing that wasn't what they wanted. And, you know, well, look at the film we saw last time again. I mean, you don't need a quantitative study to show that film is diagnosing something very wrong in our healthcare system, and that message needs to be brought forward. What's the best way to bring it forward? Well, films like that actually are a compelling way to bring it forward. That should be shown to more doctors and administrators and so on. Yeah. So, I mean, there's a couple of issues behind what you're saying. So you're expressing the dilemma that many of us face, which is that within mainstream psychology, psychiatry, most health disciplines, nursing would be an exception, maybe social work to some degree an exception. Qualitative research is not given a lot of weight or credibility. And what was viewed as evidence is quantitative, experimental, epidemiological. The bigger the N, the more rigorous the measures, et cetera, the more credible the thing. And there are reasons for that, some legitimate reasons in certain areas, but the problem is that's not the right method to show certain things, and certain things can be shown very compellingly with a single case study, and it's unequivocal. In other words, if there's not a lot of random variation, if something's open and shut, you don't need a big statistical study. You just need, the demonstration of these things. So, so there's a whole education process that has to go on. Rob Whitley, one of our colleagues here, wrote an article some years ago in Canadian Journal of Psychiatry on qualitative research, just educating really the community on these are some of the methods and these are the things these things can show, and they need to be there, they need to be on the table. That's an uphill battle, it's an ongoing issue, and some of it's based on misunderstandings of what the research can and can't do. Some of it's based on bad research that oversells what it has to offer, but people need to understand these complementaries, and we have to keep pushing for it. That's all I can say. I mean, we're involved right now with a grant proposal with people from involved with global health from Africa who are very centrally involved with this cross-national epidemiology work, but they've come to us saying, well, we want to build into this a qualitative component that will look ethnographically at idioms of distress and so on. So there's a chance to do a little bit of what I'm talking to you about today, and I think that work goes on in parallel. I think it's an uphill battle, and there's a lot at stake behind this. Even within psychology, of course, I mean, psychology has bifurcated into different traditions. So you have discursive psychology, and you have other people doing very qualitative work at this point who consider themselves psychologists. They have to form different societies, different groups, and different journals because they don't have a lot of dialogue. And sometimes people, this comes back to this earlier statement about incommensurability. People say, well, we're just completely in different paradigms. My take, and this is where I think health services and health settings are important, is, well, wait a minute, if we have a common object of concern, if it's this suffering person we're all concerned about, then we have a common measure in the end of whether we're saying anything useful. And we actually do have a basis for talking to each other. And so maybe we should sit still and listen and see if what that other person is saying says something pertinent about this problem in front of me that I'm trying to understand. So that's the environment we try to create, where then we listen to very different styles and approaches and try to ask, is this, and at the very least, you can probably get most quantitative researchers to agree that qualitative research has heuristic value. That is to say, you might come up with some ideas that we should test or some variables that we should learn how to operationalize or something like that, so fair enough, that has a role. That's the most conservative end. And as I say, there's another end of saying, look, there's certain things that are just open and shut examples. You don't need a lot of things to see that there's a certain problem here, and a simple case description is enough to make that point, kind of. So that has a role too. There's the in-between area of theory building and so on that many people don't want to get involved with, and I guess the proof is in the pudding in the end. What do you have to offer coming out of that other people can work with? So I'll just mention, a paper that I just finished that just is coming out in Social Science and Medicine tries to make that argument that because we have now in psychology and psychiatry and so on this evidence-based practice and evidence-based medicine, this whole notion that we're going to re-ground our work on more solid weighing of the evidence. And that comes out of a legitimate concern that a lot of clinical practice was basically people's prejudices, that I was trained in this approach, so I do this approach. And Freud said so-and-so, therefore it's true. You know, it looks a lot like a religious tradition. If Freud said this, we can't question that, or we have to make sure it's okay with Freud before we do it, you know, on and on. So there was a lot of concern that this is not working well, and also more mundanely that people just overgeneralize from their immediate experience. So I saw a patient with such and such yesterday, and they seem to get better with this, so maybe this is working, I'll do this today. That's not good enough in terms of, you know, really being sure that things are working. So the argument is you should be using very good randomized clinical trials, meta-analyses of these and so on, and that will be the basis. There are many problems with that claim. I mean, the first being that evidence is limited in most areas. So you can't answer a lot of questions with that at all, so then you're stuck. And the problem sometimes is the absence of an answer is taken as, well, we won't even go there, we won't even do that because we don't know what to do. So that's a problem. The accrual of evidence is very uneven because who can pay for the accrual of evidence is people who are going to make money off it for the most part. So we have lots of evidence about lots of drugs and not about certain other things. We happen to have a lot of evidence about cognitive behavior therapy because lots of people have to get PhDs in psychology, and a way to do that is to do a little study on cognitive behavior therapy. So just as much as drugs are oversold because they're tested, CBT is oversold rather than 100 other kinds of therapy that might work equally well because that's what everybody's getting their PhD on. So anyway, there are a lot of distortions in terms of the accumulation of evidence. It's not like a level thing. Let's take 10 good possibilities, we'll test all of them, we'll see which ones work. That mostly doesn't happen. And then there's this really deep set of questions about how do we define what is a good outcome? So for a drug study, people define a good outcome in terms of symptoms at a relatively short period of time. So you don't know, outside of those symptoms that are being measured, how well is this affecting? Are there other things that are troubling people? How much longer, you know, 6 months or a year later, how's this doing? The example I gave the other day of the person who takes a pill and maybe feels better, but also thinks it's the pill that's making me better. So they feel better, but they're also developing a kind of emotional, psychological dependence, if you will, on the idea that they have to have this pill. Well, that's usually not measured in those kinds of studies. Nobody's interested in that. So there's a million of these other things that are not on the plate. So the interesting cultural issue would be to say, well, what about trying to understand outcome in a much broader way, to go and learn with people what are the desirable outcomes, either with spontaneous healing or with their own goals, and build a much richer set of goals into our measures of outcome. Well, the thing is that there are people doing this other kind of work, and the anti-psychiatry movement evolved into people doing a variety of kinds of critical research and so on. There still is a kind of critical psychiatry network. If you're interested, Sami Tamimi and people have one based in England where people are arguing that we should be eliminating the diagnosis of schizophrenia and other kinds of things. I don't know how much impact that's going to have on the mainstream, but these are keeping alive particular discussions and critiques. For me, the important thing is really to try certain ideas out, to experiment with how they work, to see what kinds of other approaches we can develop. And I don't see it as, you know, changing the whole system is a bigger issue, right? I mean, that we should be, what was it Ian Gold said, occupy psychiatry, you know? But again, you know, just as the critique with Occupy, you know, Wall Street was, okay, what's the alternative? I mean, that also is the challenge. So I think looking at alternatives, and again, part of the interest of cross-cultural work is to go and say, okay, so do people have alternatives? And what do they already have going on? And can we learn from that? Having said that, I would not romanticize the alternatives. In other words, it's not that something's great everywhere else and we've screwed things up totally. I think it's a mix everywhere, and there are good things and bad things about our system, and our system also reflects where we are at as people, as a society at the moment, when we have the psychiatry we deserve, you know. or that we've created that reflects other aspects of our society. If we start changing our society in certain ways, those things will evolve in certain ways. So when you ask the biggest questions, you're asking questions not just about psychiatry or about mental health, but about our notions of personhood, our notions of well-being, our notions of human relationships and community and solidarity and so on, which are all worthwhile questions to ask, and which we will maybe be able to say a bit more about as we go along in this course with some other examples. But I wouldn't want you to get discouraged about the more mundane work when because you have the big issue in sight and you think, but the dominant powers are such and the economic states are such that all this is just going to be a little percolating along the bottom. I think it's still worth attacking those larger questions and trying to make a difference in those larger questions. Because I also think that it's with that kind of evidence and with that kind of clarity that there's a chance of prevailing at some point. Now, having said that, there is the flip side, there is the political side to all this. And if you say, well, how does change happen? Well, the reason there was more culture in DSM-4 was because of a certain kind of lobbying and a certain kind of presence of a constituency of Hispanic psychiatrists, Asian American psychiatrists, of recognition of changing demography in the society, of the NIMH Office of Special Populations supporting this work, and at one point, as I mentioned, really putting pressure on the APA editorial committee for DSM to include cultural issues. So there was a very political kind of process, and that has to be there too. But I'm always leery when it gets framed just as politics, because we can say this whole area of culture is a political issue about voice of different peoples and different groups and oppressed groups and so on. But if people treat it just as that, then there's also a risk that it gets marginalized. Like typically we'll say, oh yes, it's very important. Of course we have to respect culture. Now can we get back to work? As though the work itself is essentially going to be the same, versus saying, well, yes, you should respect culture, and that's a political issue, and you need to pay attention to that, and there's some different substance to what you should be doing if you take culture seriously. So I'd like to see change happen on both those levels. I wouldn't eschew the political, that's where structural change may occur, but I wouldn't also put aside the idea of just trying to accrue some basic evidence of what differences make a difference. Exactly. That's why I mentioned earlier, one of the most striking studies that won't, areas of evidence that won't go away so easily. I showed you briefly this side by a paper by Cantor-Gray on a meta-analysis of studies on the incidence of psychotic illness in migrants. So here's many studies have been done, so many that you can do this nice meta-analysis and you can show that there really is a persistent effect. So that's something everybody in the area of schizophrenia is interested in that, I would say. Everybody in the area of schizophrenia feels like that's something that has to be explained. Some people may still think we're going to find a simple biological explanation for that. But the weight of evidence is not in that direction, so it's put social factors very powerfully on the map. I also believe that what's happening with social and cultural neuroscience, which is showing more and more sort of all these profound impacts of interpersonal interaction, is going to help to make a strong link between the kinds of social processes phenomena that we're talking about here and the core models we have of psychiatric disorder. So there'll be more credibility, not less, as time goes on. So I guess we can apply this idea of validity to the problem of cross-cultural translation. So let's say we have a measure of depression now. We have the Beck Depression Inventory or the Center for Epidemiologic Studies Depression Scale or some other commonly used measure. And we say, okay, now we're going to Italy or we're going to Addis Ababa and we want a version that will work there. So we need to translate it. And the question is, what is translation? What do we do with translation? And this is a really interesting issue and a really deep issue, again, about culture. Because many of you in the room know more than one language and may know them well enough to really appreciate what things go easily from one language to another and what things really do not go easily at all. Now, there's virtually nothing that you can't eventually explain to somebody, but you might have to talk for an hour to explain to them what you really mean by this word or by this phrase. And in so doing, what you would be doing is you'd be telling a cultural history, a social context, personal biography. You'd have to create all of that context to say, this is what this word means when you're in such and such a situation, a scenario, etc., etc. This is what you feel. And then a person would have an inkling, although they might not have a full understanding because they wouldn't have had the developmental history that you have, but they'd at least be able to imagine partly what's going on. So the word honor, for example, is something that you can translate in many languages, but there are many languages where there are many kinds of honor. and where they're very important, where there's a lot of social life that's organized around how you manage honor, how you manage a man's honor or a family's honor, or the honor that you experience in certain kinds of encounters. And to understand those means to understand not just the word, but a form of life. So that's the challenge with translation. It's not the kind of stuff that people usually worry about too much in translation. Usually, what's assumed is that it should be possible to achieve meaning equivalence, and that the challenge is just getting a good, faithful translation. And if you are unable to do that, you need to search harder, or maybe you just throw out certain items. And the simplest reason is because, let's say somebody's talking about working in a factory, and you're in a rural part of the world where there are no factories, so you can't talk about factories. Or you're talking to Inuit in the Arctic, and you're talking a lot about trees, and there are no trees. You're above the tree line, so it's not a good idea to put trees in there, although everybody knows what a tree is, but it's not a good idea to put it in your example. So that's the simple level, but as I say, it gets much more complicated when you're using emotion words and words about relationships and so on, because they contain within them, or they're built on, a whole bunch of background knowledge that people have about culture and about context. The standard way to do cross-cultural translation is you get bilingual translators, people who are fluently bilingual. They take the English or the French or the German or the whatever version you have, and they translate it into the other language. Then another translator takes that version, and without having seen ever the original version, they translate it back. Then you take the two original versions, the two English, let's say, versions together, and you look and you say, whoops, what happened there? And you discover, for example, that certain words that are polysemous, the same word means many different things, got translated the wrong way because the person didn't understand what the question was or the context or whatever. You can see an extreme example of this if you use Google Translator or Babelfish or something, where sometimes they work pretty good these days. They make the algorithms more and more complicated. In effect, the algorithms are looking more and more, a little bit of context around the word and so on. But you often get these weird translations that, yeah, that is a meaning of that word, but it's absolutely not the meaning that was intended in this context. So that's one kind of mistake. But I say the deeper kinds of mistakes or deeper kind of problems in translation are because the word itself refers to a kind of concept that implies knowing something about a kind of relationship, a kind of social role, a kind of a predicament. What you do, though, is you find those discrepancies and you try to fix the discrepancies. You bring the translators together or a third person, you figure out what's an answer and so on. I should mention that when you're choosing translators for this kind of work, it's important to get people who speak the everyday language of the people that you want to work with. Typically, in healthcare settings, you end up with somebody who's a health professional from another place, who's had a very high level of education, and when they do the translation, they're often doing it at a level that the average person from that same background could not read. There's all kinds of technical words and fancy phrases, and it's just not natural language. So people have to be aware that, look, we'd like you to do this for somebody with an elementary education who could really read this well and so on. So that's another aspect of it. Having done the translation now to your satisfaction, you now want to then test to see that these things line up, and you can do that in a variety of ways with psychometric testing to show that this thing hangs together the same way, it's working the same way, it correlates with the same things, and so on. So there's a whole process of doing that. Now, most people do this in research studies, and it gets perhaps one line in the methodology. The instruments were translated and checked by blind back translation. Differences were, maybe in second sentence, differences were resolved by discussion among the translators. I say it's rare that you even see that, and usually it's even less than that. And I think this is a terrible loss, because actually the process of translation and the struggles of translation can teach us really interesting things about other cultures. But unless you're a qualitative researcher, an anthropologist or something, you're not that interested in this, and you're not going to get credit for writing an article about this, I guess. But this is an appeal to all of you who do this kind of work to try to put more papers out there that actually talk about what was hard to translate and what your solution was. Not the mundane ones, like we couldn't talk about mailboxes because nobody has a mailbox, but the ones that say the word honor in this culture has 5 different meanings and we weren't sure which one to use, and this is the one we chose, et cetera, et cetera, et cetera. That is really interesting. This is a form that Mark van Omeren developed when he was doing this kind of work in Nepal, where basically, they said, instead of just doing this work and then it disappearing and it just gets one line in the methodology, let's document what we're doing. Let's keep track of all the struggles that we had in the information. So this kind of recording form for translation problems then becomes raw material, data that can be inputted then into the kind of analysis I'm talking about. So this is an appeal to encourage people to think about that kind of work more. Okay, so the basic issue with any of these measures that we're talking about, diagnostic constructs, measures of distress, any kind of thing we might want to translate, is we're always trying to validate it against something else. And one of the most basic things to validate things against are how well are people functioning. So the challenge is, how do we find a measure of functional status? And as I say, on the face of it, I implied earlier that you can just tell that, right? Somebody's not doing well. But it's not so easy. What does it mean to not do well? If you're an ultra-Orthodox Jew living in Outremont, Montreal, a young man, the most important thing for you is that you can go to the yeshiva and study. So as long as you can prop yourself up in the morning and go and stand in front of the book all day reading or appearing to read, you're sort of semi-functioning. And there may be a lot of other things you can't do, but at least you're doing that. In another setting, if you're a woman in a certain kind of context, if you can get up and cook a meal, you're functioning, and maybe there are a lot of other things you can't do. So understanding what people are looking for and what they need and what makes a difference, what will give them a value, social status, and give them self-esteem and so on, is very important. So Paul Bolton some years ago suggested a rudimentary way of doing this, which really just begins by, again, a quasi-ethnographic thing, going into the community, talking to people, talking to key informants, and doing kind of free listing. That is just getting people to list what are all the kinds of tasks that are important to the local community. What are the things that people do in self-care and care for others and everything. So you just get a long list of these things. And then you create a community-specific questionnaire on how much individual people are doing these things. And then you can go ahead and administer that to people and see. So now you've got a locally adapted measure. The WHO has done this with disability measures in broad domains. So they've been able to, without getting down to all the specifics, they're able to just name broad domains. But you may have more cultural validity by getting down to these more specific elements. So just a few issues about the broader context of research then. That's what I'm going to say about validity for the moment here. And I just want to say a few things that are related maybe to the comments that were made earlier by people around addressing the broad issues. So one is that mental health in general tends to focus on people who are sick and people who are seen in clinical settings, that's how our theories are constructed, and that's where most of the research gets done. So we can argue for the value across cultures of expanding the context that we're looking at people in their families, in their communities, and how those other systems work, both in terms of helping people to get better from everyday ups and downs, mobilizing to help people to go get help, helping people to cope with chronic illness. All of that is very important, and it all occurs for the most part outside the healthcare setting. Given that most of us live and work in urban settings, we sort of have one map of how this works, and everything's, you have easy access to all kinds of things in the city. It's very different when you're in a rural setting and where there's more self-sufficiency, or has to be more self-sufficiency of a smaller unit, and I think that's the kind of thing we're talking about studying in this context. Another thing that happens in looking at cultural work is there's a tendency, I mentioned this earlier, to put culture, since this whole discussion occurs from the point of view of professionals who often represent the dominant group, culture is something the other person has, right? We don't have culture, we're just doing, healthcare or social work or whatever. We're professionals, we just do that thing. They have culture, we have to figure out their culture. Rather than adopting this broader perspective that says, well, of course, we have our own culture, our own personal cultural background, but also our own professional cultural systems. And what we have here is an encounter, an interaction between different systems or within a system, and that's what we're trying to analyze. So that's just a whole other set of kinds of work. It means looking at the culture of psychiatry. It means studying how different things are being done and how professionals think and so on and so forth. And I think all of that's important. It also means understanding the other person's culture, not just as a problem for you, like, oh, how come they don't see things the way I see them? Maybe it's just a problem of mental health literacy. We have to get everybody to understand our language of mental health, versus maybe there are things to be learned from the other person, from their background, from their perspective. This, I think, just returns to the point we were making earlier about intervention research. In fact, and this is it's cut off at the bottom of the paper I was mentioning to you that tries to talk about this idea of communities having their own ways of knowing, their own ideas of what an important outcome is, and those introduce new ideas that can be incorporated into intervention research. And I think this is an important issue in the context of evidence-based medicine, because the answer might be not that we don't care about evidence, but that what we're interested in is evidence about what? That there are other things we're interested in, there are other concerns we have about how this affects the family or how this will affect the person's long-term situation in the community, that those things need to be on the map along with alternative treatments. And all of this really has to do with understanding things in a larger kind of contextual frame that we could call social ecological, the idea that there's a social world, that things are interacting, that different agents and different cultural systems are interacting within that social world, and we need to be understanding that. And finally, that we need to be focusing not just on pathology, but also on health and well-being. I'll just mention this as an aside, that when people try to look at these things in a broader perspective, and in this case at the issue of functioning, so in the development of the WHO disability schedules, they went around and tried to collect from people what they viewed as important functioning and so on, and they came up with these very broad categories, tried to frame them at a sufficiently abstract level. We have understanding and communicating with the world around you, getting around, self-care, getting along with people, life activities, participation in society. These are very broad general things. To make them specific, you'd be getting into very particular notions of how people live, fair enough. And this is what they managed to get. However, they found soon afterward that there were other dimensions. And in the case of quality of life, maybe this isn't the right slide to make this point. Maybe I'm not going to have it here. But just to make the point that what they found in doing similar work around quality of life was, after they had these broad dimensions, there were other residual things that came out. And in the end, they were forced to add a whole other dimension that was essentially spirituality. People are saying, what's important to me in my quality of life is my spirituality. And under that were all kinds of specific things depending upon the tradition and the community people were in. And interestingly, in that work, they ended up with a few dimensions, but there is a lot of other culture-specific things that came out in that work that don't appear in those broad dimensions, because their goal, again, is to come up with a similar framework rather than working with this other stuff. Okay, two last things I want to talk about before we end. One has to do with working with illness narratives. So this has been of some interest to us because of the idea that there are two places that the richness of culture resides. One is in the actual configurations of communal life and social interaction, institutions and practices, and the other is in the rich representations that people have in language, in their own imagination, in their stories, and so on. And the two are interrelated. The institutions are a way that language is embodied and expressed, and the institutions and the practices are reflected in people's stories. So we've been very interested in trying to get at some of the richness of people's illness experience through stories, and there are a variety of efforts that have been made to try to do this. We mentioned last time this instrument, and someone had asked for more information about this. We're going to talk about it. The explanatory model interview catalog, which is a particular tool to try to collect narrative information about people's illness experience, qualitative interviews, in such a way that can also be coded and used quantitatively if one wants to do that. And this was a tool that was developed by the psychiatrist anthropologist Mitchell Weiss, who's now at the Swiss Tropical Institute. And what he was interested in was, can we look at explanatory models, which is an idea that Arthur Kleinman had introduced, arguing that people have their own ideas of illness. Earlier, social scientists have made a distinction between illness and disease. Disease being the kind of constructs that medicine uses of different kinds of human problems, and illness being the subjective categories that people and experience that people have of their own state of distress. And the argument being that illness and disease don't always line up completely. A person can have illness without disease, disease without illness. The dimensions of their illness can be different than the dimensions of their disease, and that these are both important information. And people have their own explanatory models that feed into their illness experience, and so the explanatory model interview catalog was a way to try to get at those explanatory models. And I'm going to talk about that a little bit. I'm going to talk about the McGill illness narrative interview. Just to say these other things on here, there's a short explanatory model interview that people developed that just is an attempt to get a few of these elements of the explanatory model, and the turning point interview, which is something that Ellen Kirmayer developed to look at the experience of psychosis, and then there's some other kinds of interviews that people use. Yes? There are instruments used. I'm going to block on the name now. Mary Mann has an instrument for looking at attachment histories and using that to diagnose people's attachment problems. In itself, it's not a cultural instrument, but it's been used in cross-cultural research. And I think there are a lot of other narrative instruments that try to get at, by asking people lots of information about certain kinds of life experiences, collect that information, and then they have coding schemes. And in some cases, they ultimately are quantitative measures. That is, they collect narrative material, but then they code it quantitatively. What I'm going to be talking about now is tools that are really used for more ethnographic research at getting at more specifically things like people's cultural understandings of illness. So, and the two main ones I'm going to talk about are the EMIC and the McGill illness narrative interview. Just briefly, each of them. So the EMIC, which again stands for Explanatory Model Interview Catalog, but you caught that this is also intentionally meant to be referring to this idea of EMIC versus EDIC that I referred to earlier. The content of this interview is that it covers the patterns of distress, that is, the kinds of symptoms and illness-related experiences a person's having, but also stuff about social background and so on. It covers people's perceived causes of problems in different domains. It covers their help seeking and treatment, and their general illness beliefs and disease-specific queries. Now, the EMIC is not a completely standardized instrument. These are all potential categories. It needs to be modified and developed for each particular context. These questions are all open-ended questions that ask about different domains, and it's been used in some contexts with actually two people, one person doing the interview and another person doing recording. So it can not only be audio recorded, but being sort of coded as they go along in certain ways. The actual structure of the interview looks like this. There's an empowering introduction to explain the nature of the queries and encouraging the person to be open. One of the dilemmas in doing this kind of work, particularly if you yourself are a healthcare provider, is to ask somebody about their cultural beliefs is incongruous. I mean, they're coming to you, you're the expert, you're supposed to tell them what the problem is. They find it peculiar that you want to know what they think, and you may not get candid answers because people don't want to tell you things that they think you think are going to be foolish or not sophisticated or whatever. So there's a whole issue of the kind of rapport you have with people and the kind of things you need to say and do to create a relationship in which they feel that it is safe and that it is wise for them to tell you all these other things that they think might be going on or that other people in their family think might be going on and so on. The aim and what makes this particularly a narrative interview and a qualitative interview is the idea to impose minimal structure to really get people's free descriptions of things. They're not free, they're elicited, but they still are structured the way that people themselves are describing them. And then the idea is because the aim here is to work toward a kind of coding, that there's a process of weighing, if people give multiple answers, deciding which is the most important, and so on. And then in the end, one has codes, but one can also have a kind of written narrative of what the story is. So this is a tool that's been used in a variety of studies by Mitchell Weiss and by others. It is very labor-intensive and very lengthy and challenging, which is why it has not been used that much, I suppose, and why people have tried to develop short forms. We had another concern at McGill coming out of the work of Alan Young, who early on, soon after Arthur Kleinman was writing about the idea of explanatory models, published a couple of papers critical of the idea of the explanatory model perspective. I have here called When Rational Men Fall Sick. And basically argued that the explanatory model perspective, which implied that people had a clear model of their illness and knew what the cause was and what it was called and what it would lead to and so on, was an implicit model of everybody as being a highly rationalistic male. I say male because, again, in Western society, rationality is also gendered in a way in everyday thinking. And so His observations from his work in rural Ethiopia was that most people, when you ask them about illness, do not have anywhere near such a systematic account of what's going on. They really give you a very patchwork kind of account that draws bits and pieces from different things they've experienced, things they heard about, things that might be the case. And it's only really if somebody's had a long chronic illness and they've been involved a lot in healthcare that they begin to end up with a very systematized picture that they can trot out and give you all the time. And Alan in particular, based on this in these articles, and the second article, argued that in his material you could see at least 3 different kinds of knowledge structure that people were using in trying to give an account of their illness. There were explanatory models to some degree where people would say, oh yes, this is called such and such and it's caused by this and so on. But there were also prototypes. That is, somebody just said, oh, this happened to my uncle and I think it's happening to me now. They would just, or this happened to me once before and it's happening to me exactly the same way. Or I saw on TV the other day that this such and such is this, I think that's what's happening to me. So it was not an explanatory model in the sense that they knew a cause, knew a mechanism, but that they were invoking a vivid template or a prototype, in effect, to reason about their own. So it's a kind of analogical reasoning from some vivid image or story. And then a lot of it was what he called chain complexes, borrowing a term from Vygotsky, that just argued that things just happen. They just happen in that way. This happens, then that happens, then that happens. So there's just a kind of narrative of contiguity. It's not a causal explanation. It's not a coherent image. And a lot was told that way. And what he found was the stories people were giving him were a mixture of these 3 things, in a way. So we decided that rather than, when you ask somebody, what do you call this illness, and what do people do, etc., you're pushing people to give you a very formulaic account. If I ask you, tell me about diabetes, you're going to trot out whatever you've heard in general. But if you are having a problem, you may or may not be using that scheme. There may be other things at play. So we tried to devise something that would get at these different kinds of information in different ways, and you can see different questions that would tend to give that. If you ask what caused your symptoms, you're pushing people toward a kind of explanatory model. If you ask, have you ever had anything like this before, it's a very different kind of question. A person's searching their memory for something, or do you know anybody else who's had anything like this? You're getting at more of a prototype. And if you just say what happened to you, and what happened then, and what happened then, you're getting a more unstructured, more just this model of contiguity. And so what we do is we created an interview that goes from the least structured to the most structured. So it actually asks first just what happened, then it asks for prototypes, and only after that does it ask for explanatory models. Because the idea, again, once you get the explanatory model, once people have said, well, this is what it is, I think, then they have to tell their story in a way that's consistent with that, just to be consistent with themselves. So you miss the opportunity to get the more open-ended thing. So we have this thing called the McGill Illness Narrative Interview that we've been using to try to look at illness experiences. When I told you the stuff the other day about Feng Tap and Wat Wook, it came from using this kind of illness narrative interview with people. This is the first part, which is the chain complex part, which is just really getting the person's initial narrative. And then there's a second part that looks at prototypes. And then only after that is there a third part that asks about explanatory models, and this is built on the questions that Arthur Kleinman originally proposed that really focus on causality and so on, and then some other things about help seeking. This is the Tibetan version of the McGill Illness Narrative Interview, which was used with healers in Mustang in Nepal. So I'm very tickled by that. I think it's cute to see it. It's a beautiful script. It's cute to see that. And there's an interesting paper by Sienna Craig called "Taking the Mini to Mustang," in which she talks about parts of this that worked and parts of this that didn't work, because it's interesting again that this still implies certain ways of thinking, certain structured ways of thinking. And she found that the healers, the shamans that she was talking to, there's certain aspects of this that didn't make any sense to them to ask the questions that way. So I think there's a lot to be learned still about how people narrate illness and different cultural modes of narration. And as with other things, by using a tool that's developed in one area, we may be making mistakes, but we're also going to learn things as we find out that it doesn't work in certain ways. If we can document that, we can learn something significant about narrative styles. Last thing I want to talk about briefly then is the looping effect. So we've saved the best for last. And this, as I already mentioned, is this issue. This is, in some ways, it's like an extension of this category fallacy. It's also an extension of the idea of labeling theory that was popular in the 50s and 60s, the idea that once you label somebody with something, that gives them a new social identity and it has consequences. If I label somebody as mad or as depressed, it has social consequences and it can be self-perpetuating, right? So Ian Hacking, a philosopher of science, made the argument that psychiatric disorders, many psychiatric disorders, function as human kinds, and they are maintained by this looping effect. That once a label becomes popular and people take it on, it reorganizes their experience, and then they act in such a way that it is self-fulfilling prophecy. And the example he used in this book, Mad Travelers, was hysterical fugue. In the 1800s in France. There was a period where there were many people, significant number of people, at least to medical attention, who were having episodes where they would forget who they were, travel to another city, and take on a new identity. This is a rare phenomenon that, well, a rare phenomenon as a medical illness. I don't know how many people run away from where they are and take on a new identity. It may actually be fairly frequent. But, I mean, you know, people escaping debts or you know, a marriage or something else. But this was a phenomenon that occurred at a certain period of time in France, in particular. And he talks about this as a transient mental illness, in the sense that it had a period of, you know, 20 or 30 years where it became frequent, and then it became infrequent again. And what was making it frequent was people were writing and talking about it, and it became an interesting object. And there were also other vectors. He argues that there were other social vectors that were contributing to this becoming popular at that time. The institution of train travel, of relatively inexpensive train travel, so people could go far away across Europe suddenly. People being discharged from the military who themselves had already been mobile to some degree. A variety of kind of social changes that were occurring that made the possibility of going somewhere else and adopting another identity more thinkable and more possible, interacting then with distress and with other kinds of social pressures to give rise to this. But the labeling of this problem and the framing of it as a medical problem by psychiatrists was an important part of that looping process. And then in the later book, I don't have it here, there's a book called, well, you've got Kinds of People here. He has a book that I didn't put on here called Rewriting the Self. I think that's correct. Which is Rewriting the Soul. Rewriting the Soul, which is really about the rise of multiple personality disorder and the way in which the influence of attitudes toward trauma and toward childhood trauma and so on created a social space in which many people were looking for and expecting to find an illness like multiple personality disorder, and more cases appeared. I'm going to talk about this in more detail on Tuesday under the rubric of dissociation, so I won't make more of it right now, but just to make the point that he gives a variety of examples, mostly in the area of what would have been called in the past hysteria. So areas where we know symptoms are very malleable, where people have symptoms that are very culturally shaped in ways and that can sometimes be very odd and unusual because they fit with people's cultural expectations. So the notion is that we have two kinds of loops going on. We have the inner loop that I talked about last time that are part of things like cognitive, emotional, bodily experiences that then become part of anxiety or panic and that can become vicious circles. And we have an outer, more social, sociological loop in which certain kinds of distress are being labeled certain ways. People are being offered treatments. They take the treatments. They feel better. They tell everybody else, this worked for me. Why don't you try this? I think I might have had depression. Maybe you look depressed. Maybe you should get this, etc., etc. And these things take on a life of their own. They become social phenomena. The example I gave you of repetitive strain injury last time in Australia is a good example of that social looping effect. So the question is, how often does this happen in psychiatric areas, and how much can we see it? And of course, it's a difficult thing to study because these are the largest scale phenomena that we're embedded in, and we mostly see it as common sense. I mean, depression is depression, right? It's not something we're creating by talking about it. So we kind of have a dilemma in terms of how we're going to study it. I want to show you, though, an example. I have these excessive diagrams here of loops and arrows and a little carried away here. I have nothing better to do with my time. But I want to show you an example here of a phenomenon of this kind of looping effect, if you will, with the example of Japan. And it's in one of the articles I gave you. When Prozac was introduced in North America and became a blockbuster drug, it made enormous sums of money for Lilly, and other selective serotonin reuptake inhibitors were introduced and just made fabulous sums of money. It was not introduced into Japan because the companies concluded there's no market for it. Nobody diagnoses depression and nobody treats depression, and so there's no market for antidepressant drugs. There's just it's a very small thing. So they didn't bother doing it, which is interesting because other medications got introduced into Japan very quickly. 6 months after Viagra was introduced, it was introduced into Japan. And in Japan, to introduce new drugs, you have to have clinical trials in Japan. So it's a big investment for the companies. They can't just say, oh, we tested it in the US, it works, so now we're giving it to you. They actually have to do separate studies. So they have to invest and they have to figure we're going to make our money back, but we're going to do all this stuff now and so on. In fact, they had done some studies with antidepressants in Japan that didn't work, but so they just sort of let that lie. But anyway. But after they sort of saturated other markets, they sort of said, well, there's still an untapped market here. So in Japanese, or, like many other places, make plenty of use of pharmaceuticals. So we should engage this market. And this is related to the issue of co-optation that was brought up. They convened a panel of experts on cultural psychiatry, which I took part in. So I know this as a participant observer from the inside, to get ideas about how to penetrate the Japanese market. That's not what we thought necessarily this was about until we were in the middle of it, but anyway, that's what it was. It was a closed meeting. There were about 10 people, and then there were about 10 people from the company looking and thinking about this and how this would help them to penetrate the market. And so I'm sure it's one of many efforts they made to get this kind of information. And one of the things they decided to do in Japan was to destigmatize depression and to make it familiar by adopting a cultural idiom. So you remember yesterday I talked about the idioms around kokoro. So they decided that depression should be called a kokoro no kaza. That is to say, really just a cold of the kokoro. Just like you get a head cold, and have to take medications because you have a runny nose and everything else. Well, this is just like that, but it affects your kokoro. So that was a way to kind of normalize it and promote it. And they did a lot of things to do that. There's books on it that were published in the popular press. There was information to explain to people, here's the biology, here are the synapses, and so on, that explain depression. There were manga that were created where people would then talk to each other about, well, you had this problem I didn't realize. With, just guts and willpower alone is not enough. You have to go to the doctor and get some help. And now that I've seen the doctor and gotten my medicine, I'm all fine. Along with this was a whole psychologization. So not only were people introducing medication, but they were starting to introduce mentaro clinicus, mental clinics. And so you start seeing on streets in Tokyo signs for mental health clinics where people could go and get psychotherapy. So the whole mental health area is everything is parasitic on everything else. Everything benefits from everything else and kind of reinforces it. So then you have this phenomenon. People are trying to introduce this. This is the situation in Japan here, first of all, just in terms of the context that you need to understand where this is happening a little bit, at least until recent times. This is what happened globally in many developed countries in terms of psychiatric beds. Throughout the 60s, 70s, 80s, there was a process of deinstitutionalization, of reducing the number of psychiatric beds. This is the pattern of psychiatric beds in Japan during the same period of time. Psychiatric beds ran as small psychiatric hospitals run by individual clinicians, where people with chronic mental illness were largely warehoused and would spend, many, many years, and families would pay to have the family member taken care of. These are people with severe mental illness. That's what psychiatry was. And depression, anxiety, everyday common mental disorders were not dealt with very much by psychiatry. To the extent that they were dealt with formally within the system, they were dealt with by specialists in psychosomatic medicine who prescribed anti-anxiety medications or massage or kanpo, traditional Japanese medicine, and so on. But this is what happened after they decided, okay, we're going to make a serious marketing effort to introduce antidepressants, SSR antidepressants. You see the rise of the SSR antidepressants over this period of time. You see the rise in the number of people with mood disorders being diagnosed and the sales of antidepressants going up. The last point, it means nothing here where it goes down. That's just the absence of data. It just goes straight up is what you should be looking at. So what you have, in fact, is a profound social change going on in how people are understanding their own suffering and dealing with help. So we can ask the looping question here. We can ask, is this simply that there was lots of depression in Japan that was not being recognized, not being treated, people were suffering terribly and not getting help? Maybe. Is this, on the other hand, or perhaps also, people who had a range of severities of problems, who were managing in a variety of ways, who now have learned to relabel that problem and say, I have depression, I know what I need to do is I need to go to the doctor and ask for an antidepressant. And the doctor at the same time is being educated by the pharmaceutical companies, so they know how to respond. And you now have, I mean, vectors from the outside in terms of the economic and marketing forces of the pharmaceutical industry, then interacting on the different players, different nodes in the system, and then a cycle, or mutually reinforcing cycle, of doctors, patients, hospitals, the government, insurance companies, all of whom agree this is how we should be handling this problem, and away we go. So if you want to read about this in much more detail, really a 100-year history of this, you can read Junko Kitanaka's ethnographic account of depression in Japan, which is a brilliant work, and on which some of you may have read Ethan Waters' book, what's it called now? Crazy Like Us, where he talks about the idea of depression, among other things. He has 4 case studies of problems that are sort of being exported from the US around the world, and one of the chapters is on depression, and it's basically based on her work. So if you want to get it in a much richer form, you should have a look at her book. So that's the last thing I want to say. Just really to say that we're talking then about adopting critical perspectives on what we're doing and using that to try to deal with these larger issues and to frame the questions in ways that we can contribute usefully to doing a better job in mental health and trying to counteract some of the things that might not be helpful. And that then requires a kind of use of different kind of social science strategies. And there are many strategies that we can borrow, including history, including sociological studies, science studies, and so on. So I think I've covered a very broad terrain. You've managed to sustain some reasonable amount of attention for the entire time, for which I'm deeply grateful to you, a bit amazed actually. I'm glad that we all have the weekend to look forward to. Hopefully we'll have some better weather and enjoy yourself. And I will see you Tuesday afternoon.